thanks for the opportunity to present the study. So our study from our institution is a phase 1 trial of Nab-paclitaxel-based induction, followed by Nab-paclitaxel-based concurrent chemo-irradiation in patients with previously treated head and neck cancer. So for those who treat this disease, and certainly for patients with this disease, locally recurrent head and neck cancer can remain quite challenging. For patients in whom locally recurrent head and neck cancer is not amenable to surgical resection, generally these are patients that are treated palliatively with systemic therapy, today immunotherapy. However, at our institution, we know for a number of decades that in a select set of patients, re-irradiation or chemo-irradiation can be used to provide a curative salvage for these patients. And so based on previous re-irradiation studies out of the University of Chicago, this study was designed to use Nab-paclitaxel-based induction followed by re-irradiation with the goal of curative salvage in this very difficult to treat patient population. So eligible patients had locally recurrent or second primary head and neck cancer without evidence of distant metastases. And then patients were subsequently enrolled and treated with a course of 2 cycles of induction therapy with carboplatin and nab-paclitaxel. And then in patients who didn't progress or had at least stable disease or a response or a complete response during following induction, these patients went on to receive Nab-paclitaxel-based re-irradiation. So the platform that we used was our historical institutional re-irradiation platform of 5-FU and Hydrea with twice daily hyperfractionated radiation in a week-on, week-off basis. And we looked at escalating doses of Nab-paclitaxel as well in this particular setting. And then we looked at the primary endpoint, of course, was the maximally tolerated dose and dose-limiting toxicity of Nab-paclitaxel when given with the AFHX regimen, with secondary endpoints of progression-free survival and overall survival. So you can see in the poster, when you're able to take a look, the patient characteristics, most of the patients actually had recurrent disease, about 80%, with only 14% having second primary cancers. And again, a very, very poor risk patient population. And so what we found was that the maximally tolerated dose and the recommended phase 2 dose of Nab-paclitaxel with the FHX backbone was 100 mg per meter squared, which is the same dose that we use with paclitaxel with this backbone that's been previously established. What was really interesting, though, however, was first of all, in all comers, we do still see a subset of these patients that achieve a curative salvage with this strategy. So the 4-year progression-free survival and overall survival in the overall cohort was 23% and 26% respectively. So clearly a small subset of patients that achieve a curative salvage in this particular setting with this strategy. But again, overall, very poor prognosis and really a group that we need to improve our therapeutic approaches for. Interestingly, if you look at only the patients that had some kind of response to induction chemotherapy and then received chemoradiation, the outcomes were actually better. So 4-year PFS and OS for this subset was 38% and 44% respectively. And so, the take-home messages is, in general, re-irradiation remains a very poor prognosis group with the locally recurrent patients. However, what was interesting is that chemotherapy did seem to be able to select, or response to chemotherapy did seem to select patients who may be potential candidates for this re-irradiation strategy. And of course, this study predated the immunotherapy era, and so it's quite important that we evaluate where this strategy sits within the context of the rapidly evolving therapeutic landscape with immunotherapy in recurrent head and neck cancer.